Welcome to session 3 of pharmacology. Today we'll be continuing with our learning of pharmacokinetics. In the session 2 in the pharmacokinetics, we learned about bioavailability. Bioavailability is a fraction of unchanged drug that reaches systemic circulation after its administration. It will always be less than 100%, and there are various factors which we talked about in session 2. So I hope you would have revised bioavailability and the factors which are influencing it. In today's session, we will be continuing from where we left. So we learned about absorption and distribution and bioavailability, and today in this session we'll be learning about first pass elimination and metabolism and what are the factors which are influencing a metabolism of a drug. We will also learn how the drugs are excreted out and what are the parameters or the factors influencing it. Now, what do you mean by metabolism? Metabolism is defined as a term in which a chemical modification of a drug by enzymes occurs, and that leads to more active products or less active products. So drugs like losartan, which are known as prodrugs, when they are getting metabolized by the liver, we get more active metabolite than the parent drug, right? The metabolism mostly leads to more water-soluble compound that leads to lessening or termination of drug effect. Drug metabolism mostly occurs in the liver. It can also occur sometimes in kidneys, lungs for aerosol drugs. The metabolism of the drugs is carried out by enzymes. The enzymes which are known as CYP, cytochrome P450 enzymes. These enzymes are present in the endoplasmic reticulum of the liver cell. Earlier, the thought was the metabolism used to occur in phases. That's why you'll have some textbook talking about in phase 1 and phase 2. But these days, we have them in terms under conjugation and functionalization. So a drug can undergo conjugation reaction, or it can only undergo functionalization, or it can undergo both. The main objective of metabolism is to make the drug more water soluble, and so that it can be easily excreted out from the human body. The phase 1, which is now known as functionalization reaction. In this, we have drugs being converted into more water soluble via oxidation, reduction, or hydrolysis reaction. The phase 1 metabolites are sometimes more active, or they can have a change in the duration of action. Over here, I would like to add now cytochrome P450 CYP enzymes. There are various isoforms which are known to us. For example, CYP3A4. Now CYP3A4, the number 3 will stand for the family, A for the subfamily, 4 for the isoform, right? You don't need to remember all the CYP enzymes, but as you go about learning in the particular drugs in each individual session, you will have an idea of which CYP enzyme is responsible for the metabolism. phase 2 reactions, which are now known as conjugation reaction. Earlier it was thought that drugs after undergoing phase 1 used to undergo phase 2, but it is not the case anymore. The drugs can either undergo functionalization or just conjugation, or it can undergo both of these, right? So in the conjugation, we have the drugs getting coupled with an endogenous substance like glucouronic acid, sulfate, acetyl coenzyme, or glutathione. As I already told you, the drugs are becoming more polar, water soluble, becoming easier to excrete by the kidneys, or they can be easily transported in the bile to the GIT. The conjugation reactions are catalyzed via various enzymes pathways, and they also use the endogenous coenzymes, acetyl coenzyme. Now coming to an overview, this particular diagram gives an overview of the metabolism. So on the left hand of the corner of the screen, we have the parent drug molecule. After it undergoes functionalization, that means we have a functional group being attached in the green, or you can get a conjugation, that means an oxidation or reduction can occur. So that means as these processes are being occurring, we have the drugs becoming more polar and more water soluble. So as we see, the drugs water solubility increases as the drugs are getting modified by addition of a functional group or undergoing a chemical reaction of oxidation or reduction. Now there are various factors which influence metabolism. Factors like genetic, that means certain people are poor metabolizers. Some people are able to metabolize the drug better as compared to others. We also have age. As we grow old, physiological changes leads to increase in the drug sensitivity and also potential for the drug interaction. If the person has underlying or concurrent disease condition of liver, cardiac failure, renal disease, that will also influence this ability to metabolize a particular drug. Environmental factors. Many drug interactions are related to either the induction or inhibition of metabolic enzyme activity. For example, induction. A person who smokes will have an increased activity of CYP1A2 enzyme. Now, CYP1A2 enzymes are responsible for metabolism of drugs like caffeine, theophylline, and imipramine. So a person who smokes cigarettes will metabolize these drugs faster as compared to the person who does not smoke. Drugs like phenobarbital or herbs like St. John wort, which are used in the treatment of depression, they increase the enzyme which is used for metabolism of oral contraceptive. So that means a lady who's taking St. John wort and taking oral contraceptive pills will have a higher risk of contraceptive failure as compared to the one who is not taking the combination of these two drugs or a drug herb. We also have inhibition. Sometimes the pharmacokinetic competition between the two drugs or herbs can compete for the same metabolic enzyme. That can result in the metabolism rate of one or both the drugs going down. That leads to drug toxicity. For example, cimetidine, that is an H2 antagonist. It is inhibiting the metabolism of warfarin. Warfarin is a drug which is used as an anticoagulant. So a person who is taking cimetidine, H2 antagonist for his treatment of gastric ulcers, is also on warfarin, can have a potential drug interaction reaction. As the warfarin levels goes up, that can lead to hemorrhage and sometimes even death. We also have grapefruit juice, which is also a well-known inhibitor of CYP3A4 enzymes. So for drugs like philodopine, cyclosporine, trilosome, and romapil, taken by a patient who is prescribed grapefruit juice, he will have higher drug concentrations or higher drug serum concentrations, and that can lead to greater risk of adverse effects. So we have to be very careful when a client comes to a clinic and we prescribe him grapefruit juice who is only getting these modern medicines. And you have to be careful because a single glass of grapefruit juice have an effect of as more than 24 hours. So you have to be very careful when you're going to recommend grapefruit juice to your clients. So far we have learned about conjugation and functionalization reaction and the factors which are influencing the metabolism. Coming to the first pass metabolism now, that is defined as how much of a drug is left to enter systemic circulation after it has undergone liver biotransformation. That means a drug which has undergone conjugation, functionalization reaction, and how much is then available to go into the systemic circulation. So the oral drug dose is always depends upon the rate of first pass metabolism. That means a drug which is highly first pass metabolized, it will have a higher oral dose. Right? I would like to add over here, do not confuse first pass metabolism with conjugation and functionalization reaction, please. Welcome to session 3. Now we are going to talk about excretion, how the drugs are excreted from the human body. A drug will continue to exert its pharmacological or toxic effect until it is eliminated. Now, excretion is the loss of a chemically unchanged drug or the metabolites from the body. So what we have is the routes of excretions. They can be kidney, they can be hepatic, expired air, sweat and saliva, and breast milk. So looking at kidneys, we have most of the drugs are excreted via the urine. There can be high percentage of unchanged or water-soluble drugs. Also, impairment of renal function will impair its excretion. So that's why a person, elderly patients who have decreased renal capacity, so have to be very careful. A person who has an underlying chronic renal failure or cardiac failure, their renal capacities will have been compromised as compared to the normal patients or clients. For example, morphine, which is metabolized into morphine 6-glucuronide and is excreted through the kidneys via the urine. That means a person who has an impairment in his renal function will have a buildup of the morphine in his body. So you'll have to be very careful when you're prescribing or recommending for the person to include morphine as a herb or a plant rich in morphine for its pharmacological activities. So how does the excretion by the kidneys occurs in humans? The drugs is excreted mainly by two processes, glomerular filtration and active tubular secretion. They may also be reabsorbed, usually by passive diffusion. Now looking at the excretion at the nephron. So what we have is the drug coming through the blood into the glomerulus. So if a drug which has been metabolized into more water soluble will cross over into the glomerulus, whereas the drug which is bounded to the protein will still remain in the blood system. And as we say, water is being reabsorbed, a concentration gradient gets established between the drug in the tubular fluid and the drug in the blood. So the drug is lipid soluble enough, it will cross back into the systemic circulation. And the drugs which are more water soluble will not be reabsorbed and they will be excreted in the urine. Now there are also other factors which are coming into the play. As we know, urine pH varies from 4.6 to 8.2. So depending upon the drug, whether it is acidic or basic in nature, it will be excretion rate will be determined by the pH of the urine. And also certain drug interaction can also play a role in influencing the excretion of drugs. For example, an acidic drug will be excreted out if the pH of the urine is on the alkaline scale. Or if the drug is basic in nature, it will be excreted more readily in the acidic urine as compared to alkaline urine. So that's why we can sometimes alter the pH of the urine to increase or enhance the excretion of a particular metabolite or an unchanged drug. High doses of vitamin C are known to acidify the urine. They can promote the excretion of basic drugs. So that's why you need to be very careful when you're going to prescribe vitamin C as a source of antioxidant to the clients. Because if the client is on a basic drug, then it will be excreted at a faster rate if he is on higher dose of vitamin C. And also I like to add, drugs like probenecid, they are known to inhibit uric acid, but they also inhibit the secretion of penicillin. That means a person, when he is taking probenecid, which is a uricuric agent, has a higher retention or higher plasma levels of penicillin in his body. Now moving on to the next. Now we look at how does the excretion occurs into the GIT system, the gastrointestinal tract. So after the liver metabolism, that means after the drug has been metabolized into conjugation or undergone functionalization, the drug is transported from the bile, and there in the gut system we have bacteria. Now these bacteria are known to produce enzyme called as beta-glucuronidase. For example, if a drug which has undergone a conjugation with glucuronide molecule, when it is transported via the bile into the gastrointestinal tract, it will be broken down. So the drug A, having glucuronide molecule attached to it, has a molecule broken down, and the drug A is then reabsorbed back into the portal vein. Right? So this is known as the enterohepatic recycling. That means a portion of a drug gets converted back into its parent molecule and loses its capacity to be water soluble, and it goes back into the systemic circulation. Right? There are also other factors or other routes through which the excretion occurs. Lungs. It's mostly for the drugs which are taken in the aerosol forms, for anesthetics. The drugs are being excreted in the intact form because they're not metabolized. and on expression, the agents will enter the bloodstreams and they'll be distributed into general circulation and they will be metabolized by the liver just like drugs taken through the oral routes. We also have excretion of drugs occurring through sweat, saliva, and breast milk. For the breast milk, I like to add, a breast milk has a pH of approximately 6.5. Therefore, basic compounds with low plasma protein and high lipid solubility are able to cross into the breast milk. That's why when you get a client who is lactating and breastfeeding is given drugs which are rich in narcotics or morphine, they're easily able to cross into the breast milk and can be harmful for the child. So you have to be careful when prescribing certain drugs or herbs